I'll just go through the lists. Aaron?
Hi, I'm Erin Sherman. I'm the Chief of Provider Alignment and Special Projects at the Health Services Cost Review Commission.
Okay. Willem Daniel?
Hi, my name is Will Daniel. I'm a Deputy Director at the HCRC.
I don't think we have Kenneth Yates Trotman, who is on the Maryland Healthcare Commission staff. Are you there, Kenneth? I don't think so. Megan Renfrew?
Megan won't be joining either.
Okay. I'm Paul Parker. I'm Director of Healthcare Facilities Planning and Development with the Maryland Healthcare Commission. And I think I've been designated as kind of a co-chair of this group with Willem. Ryan Burdick.
Good afternoon. My name is Ryan Burdick. I'm an analyst within Innovation Research and Development for Maryland Medicaid.
Welcome, Ryan. I don't think we have Katie Wunderlich, the Executive Director of the Health Services Cost Review Commission. Sharon Neely.
Good afternoon. I am also an analyst alongside Ryan at IRD and Medicaid.
Welcome, Sharon. Laura Goodman.
Good afternoon, Laura Goodman, Deputy Director, Medicaid Innovation Research and Development.
Thank you. Trish Roddy. Don't think we have Trish. I see Dr. Rifkin.
Hi, Scott Rifkin. I'm an internal medicine doc, and I've kind of done everything in the nursing home industry, from being a doc to being a medical director to being an owner to owning institutional special needs plans. And one of our companies, along with the help from Kevin and Joe and others, got selected as the data backbone company for this new effort that I'm sure we'll talk about at some point.
Okay. Mr. Hefner.
Hi, everybody. I'm Kevin Hefner, CEO with Lifespan Network.
And Joe D'Amatos.
Joe D'Amatos. I'm the President and CEO of the Health Facilities Association of Maryland.
And then Nelson Sabatini was the last person on my list, and I guess we don't have him today. Now, are there others who are here who I did not call out their name?
Linda Cole.
Linda Cole, sorry. Linda Cole is on the Maryland Healthcare Commission staff. She is our chief for long-term care policy and planning, and so I've asked her to kind of sit in. She's a great note taker, so I'm not. So she's going to be taking some notes, and she does have some subject matter expertise. Anyone else?
Yeah, I am Paul Miller. I'm with Lifespan Network. I'm a CPA, and I'm told that I'm a Medicare, Medicaid reimbursement nerd.
That's an act.
Nerds are welcome. So, and I guess that's it. No one else who we haven't covered here. This is the post-acute care, long-term care, and total cost of care model expansion group. I think I would summarize our objective here with this group to kind of explore where the total cost of care model is working and not working with respect to post-acute care. I think our initial focus here is going to be on skilled nursing facility care. I will freely admit that I do not have a strong understanding of really what's going on with skilled nursing facility care in the context of the total cost of care model, in terms of how we're progressing in terms of the rate of increase in expenditure compared to the national experience. I think that over time, we're going to have some sort of baseline understanding of those issues to make progress here. But I think Aaron has described the mission of this group as one of brainstorming. What are possible adjustments to the model? What are any innovative ideas we have for improving our performance on the model? with that, Willem, would you like to make some remarks as the co-chair?
We're excited to go through this brainstorming process with you guys as we design our next phase of our model.
And Paul, if you want, I'll just give a little primer about the timeline and goals. So I mentioned this in the email that I sent out when I scheduled it, but you know, we're working towards developing a written.
And we just lost.
For expanding it. You lose me?
We were losing your audio intermittently.
Oh, can you hear me now?
Yeah. So you said you were working toward.
So we're working towards developing a written progression plan for the total cost of care model to submit to CMMI at the end of the next year. And so we've set up sort of a structure where we focus on, you know, 6 kind of different priority areas that we want to make sure are incorporated into this written document that we're hoping to have a draft of in the spring of next year. So it's important, you know, to us to make sure that long-term care and post-acute care are included in this vision and included in that written document. So that's the only thing I'll add to your comments, Paul.
Okay, thank you, Aaron. So I have seen a one-pager, which I think was put together by Dr. Rifkin. And it was entitled "A Simple Plan to Improve Care in Maryland Nursing Homes." I saw a movie that was entitled "A Simple Plan," and
yeah, my problem in life is I think everything's simple. It rarely is.
It didn't go well in the movie, but maybe if no one objects, you know, we might ask Dr. Rifkin to talk about this plan. It does involve certainly some changes and innovation with respect to the total cost of care model. So why don't we start off by letting you brainstorm?
Sure, I'm happy to do that. I don't actually have it in front of me because I didn't think we were going to jump right to this, but I think I can walk through it a little bit. But I think some of the background's important. At any point, Joe or Kevin or Paul, feel free to jump in, because I think look, nursing home operators want to do a good job. They want to be important and helpful in controlling the cost of care and improving quality. There's no way to lower the cost of care without improving quality. I mean, the two go together, okay? So you start with that premise. But you also have to have the premise that they're business people. You know, most of the nursing homes are privately owned. They're not really private equity owned anymore, but they're privately owned. You know, the Genesises and the ManorCares are gone. Those organizations have been bought by various operators and owners, many from all over the country, and they're business people. And they paid a lot for those facilities. And they're going to do what business people are going to do. They're going to try to, within the rules, hopefully always within the rules, maximize the dollars they earn. I mean, that's the nature of business. So what you really got to do is figure out, how do you incent them different? Right now, there's no particular incentive to lower the cost of care at the nursing home level. And I think we don't know, and we probably need to learn in this process, is what has happened in the nursing home industry in Maryland with cost of care over the last couple of years. You know, and it's not just cost in the nursing home. The bigger cost is hospitalizations generated by the nursing home. Okay, so if your readmission rate is low at 12%, or your readmission rate is high at 30%, the national average being about 20, okay, 21, 22, there's a big difference in the amount of cost that gets generated for the Medicare system in Maryland. You know, most of the patients in a nursing home are dual eligibles. They have Medicare and they have Medicaid. Most of their day-to-day expense is on the Medicaid side, not on the Medicare side, that the waiver, and I see Joe agreeing with me. Joe, do interrupt when I screw something up, man, because you know this stuff better than I do.
I'll build upon what you're saying. You're doing great so far, but I'll add some stuff when you're done.
Sounds good. And so they're mostly paid by Medicaid. Where Medicare comes in is really two areas. On patients who come from the hospital skilled, and they might be a skilled patient in the nursing home for 5 days or 15 days or 20. And again, that length of stay is usually in the low 20s. okay? Or because they went to the hospital, and that's the much bigger expense. It's not let the stay in the nursing home matters. I don't want to say that's wrong. And the folks at Berkeley Research Group did a little down and dirty study for us last year that I'll mention in a minute about that. But the length of stay does matter to total cost of care, but the bigger expense is hospitalizations. And the opportunity is that 50 to 70% of the hospitalizations from nursing homes are avoidable. There's been lots of studies there. And the way institutional special needs plans work is preventing those admissions, and they do work. The medical loss ratio in the institutional special needs plans I'm involved with runs right around 45%. And why? Because hospitalizations are down 50 to 70%. And you do that by throwing nurse practitioners and on the backbone that the state just asked Chris to put together. And it's going live as we speak with Joe and Kevin's help. But you put those two together, you really can prevent admissions. But you still have a basic incentivization problem. Why does the nursing home operator care? You know, the hospitals care. I understand why they care. But why do the nursing home operators care? And if you're going to ask them to do what it takes, and it's work and it's money, if you're going to ask them to do what it takes to lower those hospitalizations, because that's where they can have the biggest impact, and maybe lower their length of stay as well. But if you're going to ask them to do that, you got to build some incentives into the system. And so what I was proposing, and there are probably other ways to get at this, is, let me go back to the study that Berkeley Research Group did. They did a little down and dirty on what would happen if you reduced three things in the nursing homes by 50%. And those are doable numbers. You know, in Montgomery County and Anne Arundel County, with the test project we did for the rate commission, we were down, 25%, Kevin? Something in that range, 30%? That was in the first 6 months. In the first 6 months, a drop in hospitalizations and a total cost of care drop of 6.5%. It was significant, okay, for all those cases, not just for the people that went to the hospital. And so they did a study where they looked at that across the country. And if you could reduce nationally those numbers to 50%, hospitalizations, whether the long-term care patients or the short-stay patients, both are paid by Medicare, and length of stay for Medicare in the nursing homes, okay? And I think it was a 30% drop there. The total savings nationally was about $14 billion. And in Maryland, it was somewhere around 300 million, okay? Those are significant numbers. Now, maybe it's 200 million, maybe it's 100, I don't know the answer to that. But there's a significant savings. And there's another concern, and Joe and Kevin may want to jump in here. We have a lot of new owners in Maryland. They paid a lot of money for their buildings. And it would not surprise me if some aspects of cost of care have gone up. It's just the nature of new operators. And they can be pushing, most of them are following the rules, but they're more aggressively coding, more aggressively figuring out, what the reimbursement should be. Some are probably skating the edges of what's acceptable and what's not. That does happen. But it would be very interesting to know what our baseline is, because if we look at this entire problem from the baseline from 3 years ago or 2 years ago, it ain't going to work, because I would argue that the baseline has shifted in the last year or two. And the healthcare commissioner, the rate commission, you guys might have more data on that than I do. But my suspicion is length of stay in the nursing home has gone up. Cost of care has gone up both on the Medicare and Medicaid side, and that the cost, the hospitalization rate has gone up because there's more pressure on nursing staffing, both because of the pandemic and not getting nurses, but also because of the cost involved. Okay.
So I'll jump in there, because
Sure.
that's the perfect segue. And I'll begin with what you said last, because again, I'm old and it's the freshest thing on my mind. But so I would say this. I would say that in terms of costs going up, acuity in Medicaid, I think, has gone up, but utilization is dramatically down, right? Dramatically down. And so we have two anomalies that we don't normally have in a base year in Maryland that are kind of interesting. And yeah, we should look at the data. One is obviously the pandemic and the impact it had on census in nursing homes, right? So pre-pandemic, total census in nursing homes was in the high 80s on average. It's just now at 80. It's been like 74, 75, 77% for the longest time. So, and it got down to about 70% at the low point. So, so census and utilization remain at historic lows. I think acuity, I know definitely on Medicaid, because we've looked at it, that's sort of gone up. But again, you're talking about less days of care. So total cost on the Medicaid side and the utilization probably down because you're providing fewer days of care than you did before the pandemic because census is low. On the ISIP plan that you mentioned, that just the notion of it is a brilliant example on your part. Because why ISNPs work is because they align resources, cost, and quality of care. So you're incentivized and you're funded through the insurance product to be able to pay for those nurse practitioners to round every day. And you produce greater clinical outcomes. In the end, you have savings. And in that model, you're incentivized for the savings because as a participant in insurance, you recoup the savings. So with the total cost of care, as we plan this road forward, we probably have the best potential in the country of taking aspects of the ISNP program and why it works. And looking at, Scott, you're exactly right, where you've got the savings, because on the per unit per day cost is in reducing unnecessary hospitalizations and rehospitalizations, right? So that's what gives you the savings. Just because the unit per day per cost is higher in hospitals than it is in nursing homes. So if you save that, you're getting a big bang for your buck. So the opportunity is to take what best works in, let's say, an ISNP in terms of aligning payment and quality, coming up with both clinical and financial measures. That's like a core principle that can be agreed upon, that then puts nursing homes in control of their own destiny in reducing those unnecessary hospital stays and readmissions, right? So that's what I would add to what you said. Scott, is that an alignment? Did we?
It is.
Well, there
it is. How you get there with the incentives is obviously the main topic. And
right.
when I'm simple, I always think my ideas are simple, and they probably are simple, but with a different definition of simple. So I apologize for that. But Joe made a good point. And the other problem that's out there, and Joe and Kevin, again, may want to comment on this. And I know, Kevin, you and I have spoken to hospital CEOs and CFOs for a decade and said, it is in your best interest under the Maryland system to reduce admissions for nursing homes. Why don't we create programs together that share some of that savings with the nursing homes so they give a damn about doing it? And invariably, they say, oh, no, if we do that, they'll take the money away from us. We can't do that. And getting hospitals to cooperate in those programs has been essentially impossible.
Well, Scott, I'll invite Kevin in like 5 seconds here, but here's the deal on that, right? The reason why other models 5, 6, 7, 8 years ago, other risk and risk sharing models nationally have struggled is that it generally put the savings and the decisions about the savings at the traditional upstream provider, hospitals, right? And it didn't put in their own destiny as the decider and the definite pot holder of the dollars, the traditional downstream providers, the nursing homes. So as I turn it over to Kevin, the reason it hasn't worked in those last 10 years is you're exactly right. The hospitals have said, no, that means that I'm giving away some of the money that I would have normally get. And the reason it hasn't worked on the nursing home side is they're skeptical that they won't be viewed as just a downstream vendor in control of their own destiny as opposed to a partner. So if you have a system where you agree upon clinical and financial measures in advance, the hospitals agree to share some of the savings that in a pre-existent world would have been part of theirs, the nursing homes agree to risk, but they're agreeing to the risk. The critical part of that is that they've got to be able to have the deciding factor to kind of move from a vendor to partner so they control their own destiny. And Kevin and I have talked about this a bunch, and I know the three of us has, but I want to invite Kevin to talk about that hospital perspective again, because I think that was a good tee up for him.
Yeah, thanks, Joe. I mean, I think, you know, everything that Scott and Joe have said, we're all in lockstep on this. And the one thing that's changed, and Scott alluded to it with the BRG study, but is that in the past year, the governor's office provided funding to do something fairly unique, fairly different in cooperation with HFAM, Lifespan, and CRISP, introduced a program that we're rolling out now that will help nursing homes to, with limited resources on the staffing side, be able to devote resources to where there's the greatest need. So if there's an impending hospitalization, you can use data to intervene. You know, we all like to think that directors of nursing have a firm grasp on every health detail that's involved with every resident. The reality is that they're stretched thin, just like we are, just like every other person in the nursing home is. And if they don't anticipate where there may be a hospitalization, and the classic example that we've used in conversations is Mrs. Jones hasn't had a bowel movement in the past 3 days. If we don't act specifically to intervene with Mrs. Jones, she's going to the hospital. She's going to be septic. And so this tool, and with the support of the state and the governor's office and all of the partners that I just identified, there's a tool that's available now, and it's free to nursing homes to be able to anticipate this. The challenge is, if you're able to anticipate hospitalizations and reduce the chance of those hospitalizations, you don't really have the opportunity to share in any of the savings that the hospitals will gain by not having that new person come in. And by the way, on the other side, when the person's discharged back to the nursing home, they're a skilled resident in many cases. And so there are disincentives to avoiding hospitalizations that can exist for nursing homes. So, you know, there are tools that are available now that we're rolling out, but I think the bigger conversation all revolves around, how do nursing homes, to Joe's point, have a seat at the table and be able to participate in decision-making that makes sense and saves money?
Right. So that's a great jump off for me, Kevin. So let me give a little background of the program Kevin mentioned, and then get into what that I've not even gotten into the paper I sent you guys yet. So I apologize. This is all sort of background. The program that was set up through CRISP has three components to it. One is we've linked, you know, already 65 nursing homes in the state, and I think we're getting almost all of them because there've been a lot of commitments that haven't been hooked up yet. But basically, a backbone for the system where all the data in real time. It's not billing data, it's not MDS data, it's actual real time EMR data is pulled into a software package that looks for interventional moments. Again, Kevin's mention of Mrs. Jones has had a bowel movement. That patient ends up septic 3 days later if you don't do something about it, or the heart failure patient, or the diabetic out of control, or a lot of things. And you find those interventional moments. And then there's essentially what is a call center, where nurses look at the data, call up the charge nurse and said, are you aware of A, B, and C? And by the way, here's the protocol to deal with that. That's the exact same program that was done in Anne Arundel and Montgomery counties with good success. And then the new data that's coming out, my understanding, is even better than the original data on that program. So that's sort of back. And the third thing was to be able to look for pandemic surveillance issues. That system actually gives us the first state in the country with the ability to know if there's an outbreak of infectious disease in a nursing home the same day. It's not 5 days or 8 days later like you would have in a new pandemic. You actually can search out all that and see that, and it jumps at you. Because we know the O2 saturations and blood pressures and respiratory rates and everything else that goes into a surveillance program. So anyhow, that's the background of all this. So the proposal I made, I'm not wedded to it at all. The issue was, how do you incentivize folks? Okay, how you get there. And when I spoke to Katie and all you at the rate commission, you know, Katie said something along the lines, and I don't want to speak for her, that there might be other ways to get to where I was trying to go. Okay, but what I was basically saying is, if you had the the buy-in of the state associations, Kevin and Joe, and there's a third small association, and the operators and the hospitals working together and said, okay, let's bring the nursing homes under the rate commission. Let's guarantee the nursing homes, because they won't agree to this otherwise, that they'll never get paid less than what Medicare would have paid them, but that they get to share in the savings that they help generate that the hospitals otherwise would harvest themselves. So that was part A of it. And part B was, do we have a QIP program that means something? So every state in the country, every health department got a letter from CMS 3 weeks ago, that if they don't have a QIP program, they should. And what I'm hearing from the folks in Washington is that they're going to require it. Basically, these quality improvement programs take dollars being spent on the Medicaid level, and they're they're cost neutral. They basically just say the better performers, and you can measure that any way you want to measure it, but the backbone we've created gives us almost instantaneous measurement. You could decide that decreased hospitalizations or decreased decubitus ulcers or decreased falls or increased activities of daily living, whatever you wanted to measure, would be built into the Medicaid system, so the good performers would be paid more, and those that aren't doing as well would be paid less. You could also think of doing it, because we were probably the only state in the country that could, would be to affect the Medicare payments in similar ways, and to have a QIP program around that. Good operators will welcome that. The folks that are taking real responsibility will welcome that, and it's revenue neutral. Now, Kevin and Joe may not agree with me on that point, but I think it's at least something worth looking at to see if it makes sense. And then getting back to the baseline issue, I do think it is vital for this group to get up-to-date data, and it's got to be from 22. It can't be from 21 or 20 or 19. I mean, you want those too, but we've got to know what's happened even the last year, because there's been such a dramatic turnover of ownership over the last 18 months of nursing homes in the state. And Joe or Kevin, you can tell me, but about a third of the nursing homes, it seems, are 20.
Yeah, I think it's more than a third. I mean, I think if you factor in 2019, leading into the pandemic, and last year, it's like half. So basically, what's happened in the so we started the pandemic with 227 nursing homes, and 2 small Catholic ones went out of business. So that takes us to 225. Scott, when we continued the work that you and I began together when I was in Hawaii, about a third of the market were moms and pops, and then we had about a third of the market were national companies, namely ManorCare and Genesis, and about a third were regional multis. Well, the national companies are a shadow of what they once were. I think we're down to 7 Genesis buildings in Maryland from a high of like 36 or 37. And I think we're down to literally our last one mom and pop. So really regional multis really dominate the market. Operators that operate all around the country, maybe they've got 100 or 200 homes, but in any one state they have like 20. And so they really dominate the market in Maryland now. You're right about the one thing about the quality improvement. If it's budget neutral, that means you're cutting the rate for somebody to be able to cover that. So we've always stood that you have to do new money in quality improvement programs. You can't be in a time when we're all struggling to pay 40-year high inflation and the labor costs. You can't cut the base rate and redistribute it in that way. So quality dollars would have to be new dollars.
Right. And I certainly understand that, Joe. And that's why I suggested that if there was a couple $100 million of savings,
right,
that a program like this could generate with the right incentives,
sure,
that a reasonable chunk of that go to the nursing home operators that perform. But getting back to the data, I think it's maybe one of the most important things this committee can do is start off with where's the right data. Because you got to know what that baseline is. The ownerships have changed. They have a lot more debt per bed than the previous owners had typically. And that puts them under a lot more financial strain, which sometimes has no effect on care, but sometimes does. And I think
one last point on the data, Scott, is that you're spot on, because in 2020, you had normal census data at the start of the year and relatively normal costs at the start of the year. Then at the end of the year, you had a census that was really kind of in the toilet. People weren't in nursing homes. Costs were beginning to be through the roof. And then the second surge, December through March 20 to 2021, in Maryland was worse. More people died in the second surge than in the first surge. So when you look at cost census data, you really can't get a good shot on 2021. You don't really start to get to that until 2022, when you have kind of a complete year and kind of when you start to see the inflation and all.
But there's some parameters that are separate from volume. For example, readmission rates, or those are sort of independent.
No doubt.
Will follow volume in total numbers, but the rate, the percentage, the length of stays shouldn't change.
Right.
So, and if that's something this committee can achieve as a first step, I think that would make a huge amount of sense. So I'll shut up now, and if anybody's got questions of the stuff I've been talking about, or for Kevin or Joe or myself.
Yeah, and I understand what you're saying in terms of the recent years and the difference that the pandemic has made. But looking at information through 2020, which is kind of what I've been looking at recently. So really reflecting pre-pandemic trends. Do we have a sense that going into the pandemic, there were particular utilization statistics that we saw in Maryland that deviated significantly from the national experience? So is Maryland admitting a higher proportion of Medicare patients coming out of the hospital to SNF care? Did we see a higher readmission rate, either of SNF patients or the long-term care patients from the nursing homes to the hospitals than the national experience? Do we have a high average length of stay in the hospital of patients who ultimately go on to SNF services? Do we have a high length of stay in the nursing homes of SNF patients? I've tried to tease some of that out of our data sources, looking at our public use files from our long-term care survey, and then also had a staff member here who was looking at MedPAR, actually 2021 data, as far as length of stay for SNF. That didn't look like it was too bad from what I could see with the national experience. Under 20 days average in 2021. Our long-term care data shows that, if we look at the decade of 2010 to 2020, we saw a pretty rapid increase in Medicare patient days in CCFs or nursing homes in the first 5 years of the last decade. But then it really kind of peaked and moderated after that. 2010, 16.7% of total CCF days were Medicare. That rose to 19.2% by 2015. But then in the last 5 years of that decade, it was more like 18% on average of total patient days. As a proportion of total routine service revenue, Medicare, went from 22.3% in 2010, got up to 23.8%, then moderated again, as you would expect, given the patient day trend, in the latter half of that decade. But it actually, when we look at 2020, which was obviously a pandemic year, and where we saw this sharp decline in CCF patient days, the Medicare proportion of total routine service revenue, and these statistics are all from our long-term care survey, actually hit a high of 24% in 2020. But I'm just interested, do we have a sense, pre-pandemic, did we see things about Maryland versus the national experience that that indicated problems.
Well, I mean, you're asking the right questions, Paul. So first off, and we haven't obviously seen all the data that you have seen, but you're asking the right questions. I would say anecdotally two things. I would say when we moved from the waiver to the contract and everybody understood the rules of the contract, I would say anecdotally would be that my sense would be that if you're concerned, if you're a hospital operator and you're concerned about throughput, then you're increasing your referrals to skilled nursing and rehab centers because they're leaving the hospital potentially sicker and quicker. So it would be interesting to see the correlation between the percentage of discharge from a hospital to a SNF relative to the average length of stay in the hospital, because presumably what you saw was that the percentage went up because people left the hospital sicker and quicker, necessitating more people to go to the SNF, and then they went to the SNF, right? So that's my anecdotal sense, even like pre-pandemic. I think if you look at the national data, my sense would be that when we had a higher Medicare utilization, that percentage went up, the rest of the country was going down. Would be my sense. My sense also is, even though I don't know statistically on how it correlates, that Maryland's historic relatively low penetration of Medicare Advantage plans plays a role in our numbers pre-pandemic versus the rest of the country. Paul, I see you shaking your head there.
Yeah, I was going to say, Paul, your question was, are we different than national? We have significantly lower managed care, which is what makes us so attractive to these people that are coming to buy facilities. I don't know how those numbers affect, but we are slightly different. I don't know if it's significant in the numbers, but it does make Maryland different.
Willem, can you give us any insights on that?
On the extent to which managed care has made Maryland look different than the rest of the country?
Medicare.
That and also just, the differences between how SNFs are used and the interrelationship between hospitals and SNFs in Maryland. Do we have a sense of differences that we've seen in the past?
Right. I think what we have seen is lower, even predating the Maryland model or the all-payer model, lower per capita SNF utilization, lower per capita home health and hospice utilization in Maryland than in the Medicare population nationally, and higher hospital utilization. I think some of that's probably not surprising, right? Without DRG, our length of stay has tended to be, a day or two higher than the rest of the nation, and that probably has some results in some lower SNF utilization. I think since the model has begun, we've seen our growth rates in SNF be lower than the rest of the nation. And I think our theory there is as we've been successful at reducing hospitalizations, that naturally reduces post-acute care at the same time. We've seen higher rates of home health and hospice utilization growth in Maryland than in the rest of the nation. I think we're a little uncertain whether there's a substitution effect going on there. But it's possible that hospitals have started, under global budgets trying to reduce length of stay, and as a result are using more home health and hospice. But I think we're really not sure about the mix in the post-acute care utilization, why SNF and home health and hospice are going in different directions in Maryland vis-a-vis the nation.
Do we want to have the group react to the ideas outlined by Dr. Rifkin?
You can throw all the tomatoes you want, guys. I'll dodge them.
Paul, I don't know if that was directed at everyone that's on the phone. I mean, obviously, I mean, there's, you know, there's definitely some merit to the proposal. You know, the tricky part is financing it, right? I mean, you know, increasing Medicaid rates to the Medicare rate is probably not doable. But how you end up funding that, or thinking through the additional dollars going to nursing home rates, you know, we'd have to figure out on that piece of it. So, you know, again, you know, I know, Scott, you talked about some budget neutral way. I know, Joe, you weren't in favor of that. But I think that's probably where it gets a
I don't
bit.
think Paul was either, Paul Miller.
And, you know, good or bad, I mean, I will comment on the comments around Medicare Advantage. Obviously, the department is hearing a lot from the Medicare Advantage plans in Maryland. And obviously, I think the tagline is, you know, to summarize, is, you know, the hospital rates. In other states, you can negotiate hospital rates. You can't in Maryland. So, you know, if in other states, if Medicare Advantage is more aggressive at negotiating hospital rates, obviously it provides the incentive to develop tighter relationships with nursing homes, right? So obviously that's probably one of the market dynamics that is not happening in Maryland.
And Tricia, let me add one point about Medicare Advantage. The community Medicare Advantage programs are having real trouble. And you've heard about that, and the governor gave them some more money recently. The I-SNPs, and we have some, and the Future Care folks have an I-SNP, and some other I-SNPs are in the state. They're doing fine.
Right.
And they're doing fine because there's something there's an arbitrage there in a way, and I don't know if that's the right word. But if you can reduce hospitalizations, it's much better and much more effectively than we can in the community. We can in the nursing homes, because so many of them are preventable. And we know where the patients are. We have their information, their medical records. Somebody's looking at them every day. I mean, you can have a big impact there. The MLRs in those programs are run for the care piece is around 40s and 50s. And then the remaining dollars up to 85 are being spent for nurse practitioners and data mining and paying the nursing home a fee for giving up the skilled nursing care that they're asked to give up in those programs. So the Medicare Advantage program, at least in the nursing homes, is actually working pretty well.
And so I guess my question, Scott, then is, because why wouldn't every hospital develop one of these instead of traditional Medicare Advantage? I mean, it saves them money, it gets the money out of the total cost of care. Like, why don't they just do it? It just seems like a no-brainer.
Yeah, Tricia, I'm only 42 and look 62. And the reason is hitting my head against the wall from every time I spoke to a hospital about this issue. And I know Joe and Kevin and some of the operators have had these conversations, and they have never found a willingness by a single CFO out there to have those kind of shared, you know, programs. And invariably what you hear from the CFO is, well, yeah, if we save the money, they'll take it away from us some other way.
Yeah, okay.
Their usual paranoia on these things.
But if a LifeBridge invested in an Alderwood, who already lost how much money when they ran it at University of Maryland, I don't understand it.
Nor do I, and I wish I had a better answer. And I've always thought that maybe we need more of a stick to get them to do it.
Yeah, okay. So in short, those are my comments, Paul.
Because that's the simplest approach. The simplest approach is to have the hospitals partner up with the nursing homes and say, okay, if we're going to create $12 million of savings, we'll share $3 million of that with that group of nursing homes. Suddenly, you got a real incentive for everybody to make it work.
Right, and you can work within the Medicare monies that you're paid. Whereas you've got the traditional Medicare Advantage plan saying you need 105% of the benchmark in order to make it work, and then it's on the back of the hospitals in order to increase those savings targets because Medicare is putting more money into the program.
Yeah, our ISNPs are too small. Anytime we've ever tried to negotiate hospital rates anywhere, outside of Maryland, they usually don't take our phone call. So it doesn't make any difference for us.
Right.
I think that's also pretty consistent. When we look at the literature, it doesn't really look like MA plans negotiate hospital rates nationally. I think CBO did an analysis and they found one and they realized as a part of the survey that it was a mistake and they immediately then changed the rate. So, but I agree in general with Trisha's comment, right? That why aren't these arrangements developing through conversations? I'm a little personally, and just so not speaking for HSCRC, just myself, worried about the government coming in with a stick to force a business arrangement to develop. And so I'd want to make really sure that we weren't overlooking some aspect of our model, some reason why these hospitals aren't reluctant to enter into those arrangements, and if there really is none, then maybe sort of the model that we come out of this process with is we lock you all in a room and don't let you come out until there's some agreement, right? But I'm worried about the stick, sort of forcing a hospital and a SNF into some sort of arrangement.
Yeah, no, I understand that, and I get it, but we've heard 10 years of happy talk on this stuff, and it just doesn't happen. And I'm not an expert at the reimbursement system, as you all are, of what it takes to get the hospitals to really see the benefit. Most hospital CEOs are not particularly entrepreneurial by nature. It's more important to them to be the one who doesn't make a mistake.
Right.
An entrepreneur. And it's very hard to get them to look at ways of doing things that they didn't do 20 years ago.
Right. Yeah. So I think my, sort of my bias or my prior here is that the GBRs create an incentive for them to enter into these arrangements, but there is a downside to creating revenue stability, right? Which is that it also allows you to do absolutely nothing and still be sort of marginally successful, and that the problem, at least unless we're missing something here, seems to be a cultural one, right? And I was in an economics major in undergrad. We don't believe in culture, so I don't know what the solution to that is. But I,
So I'm wide open to a really good carrot that gets them to do this. But truthfully, from what I understand, and you guys can correct me, I think you've given them a good carrot in the way the system is set up. But they don't seem to ever take that carrot. And
right. Yeah, I think we've given them a great carrot. If I could find a job where I could do less and get paid the same, I'd be really excited about it. So
right, that's a pretty decent carrot. And you were spot on when you described, you and Scott both. I think that my experience is that the hospital sector, the dominant cultural value is risk management and preservation of the status quo, because it's a pretty good system, right? And so we have to find some measure of at least, not like tactical down to like the hammer and nail, but some parameter where we can identify a group of governing principles,
right,
or, where we say, look, you will be incentivized to do this within these governing principles. You work out the details, but know that this pot of money is set aside according to these governing principles for you to enter into equal partnership with these folks, with the ultimate goal of what Dr. Rifkin shared, and that is to look at generating the most savings, which are related to avoiding unnecessary hospitalizations and rehospitalizations.
And getting back to the original point, if we get folks to do that, there's another big benefit. It's not just money. This is way better care. There is no way to prevent hospitalizations without preventing the causes of those hospitalizations. By the time somebody has chest pain, they're going to the emergency room. The real question is, can you stop those kind of things ahead of time?
Right.
So it's a nice opportunity for the state to impact care in the facilities as well.
Right, Scott, that was the point that you and I have discussed before, and with Kevin, that is a two-sided coin. If you have a goal that's purely financial, or an incentive that's purely financial, it's the wrong goal. If you have a goal that is purely quality and there's no financial component, it's the wrong goal. Really, for these objectives to work going forward, they have to be jointly agreed upon, have a financial target and a clinical target together, right?
So I think to my mind, the sort of lowest hanging fruit here would be something that looks like, HSCRC maybe creates a program where we pinky swear, we're never going to take revenue away from you for this purpose, right? And I think that's true under the GBR as it exists right now, but maybe they need that extra pinky swear and some agreement from us that says we'll never take money away from you for this purpose. Paired with that, something that says, we're going to attach a little bit of extra financial penalty to an avoidable admission from a nursing home. I think people generally are motivated by loss aversion, right? And so if we say, we want, you guys to take a little bit more financial penalties if you don't reduce your avoidable admissions from nursing homes, I think that might move them. And then try to, get you all in a room together to figure out the shared savings arrangements. I think, so I'd be interested in your guys' thoughts about that idea.
I think that's right. I haven't heard pinky swear since I was a little kid, so that's great. But I think that's great. I think you almost have to give them a model to follow. If all you say to the hospitals is form a partnership, it'll become a typical 12-year process. I mean, you guys have given them lots of money on population management. It's not my understanding that a lot of it has been very, very helpful. Okay. So I think you almost have to give them the model of how they work with the nursing homes, how they share savings with the nursing, how they measure the outcomes with the nursing homes, so that everybody's coming, it's not this protracted, we're bigger than you negotiation with the little nursing home. Right.
So I hear you there. I am nervous about it, just sharing my previous experience with hospitals. They all hate, to be told by regulators how to spend their money or structure their business arrangements. And so if we tried to, structure an arrangement for them, I think even if it were a perfectly reasonable one, there would be some reluctance to accept it just because, they don't want to be told what to do. Right. And so I think that,
I'm sorry, I'm not to tell them what it is. In other words, that they have to use the model. I think if you lay out a model they can use, it'll be a path of least resistance for them.
Yeah. So actually, I was going to suggest that would be a good role for you guys, right? So if I know, you obviously are operating in Maryland, and I think, have probably models that you could work with from your iSNPs. We've also seen nationally, there have been some very successful programs, doing intensive care management in nursing homes to reduce Medicare hospitalizations. And, it might be worth, bringing in some people who've implemented those programs and saying, to the Maryland hospitals, it really can work. Here's a doctor, dress them up in a white lab coat and everybody listens to you, sort of thing.
Yeah. Yeah. And obviously Joe and Kevin and Paul and I can get together, I would think, and come back to you with some thoughts on that. Come back to this group, if that makes sense. Yes, no.
Consensus on trying to bring in some nerdy experts for the next.
In addition to all of us nerdy experts, absolutely, absolutely.
Somebody from outside of Maryland, that might be interesting.
We all collectively know some peoples. We know some peoples.
Okay. Well, I think we've heard a couple of maybe slightly different alternatives here. The simple plan, and then maybe even a simple plan that doesn't upset hospital culture too much by trying to bring Medicare skilled nursing facility services under the rate regulation regime in Maryland. I think it seems to me that we're really kind of working toward defining what the right mixture of, you know, carrots and sticks are needed to maybe produce some cultural change. So we've been going for about an hour now. I don't know if we want to continue, if somebody's got a new and more somewhat different insight into how to approach this problem, we can do that. I think we've got some input here in this meeting to help us plan a second meeting. So if there's agreement, I think we could wind this up. I think we were planning for about an hour. I know I've got things that are supposed to be happening at 4 o'clock myself. So if it's acceptable to everyone, if anyone has any last thoughts here, why don't we wind this up?
Yeah, I promise I'm not going to take up any time. Just a clarification as we go to the next meeting. Are we looking at just SNF post-acute, or does this branch into the residential and long-term care LTSS HCBS world as well, this work group?
I know nothing on that topic. I don't know, the other people may.
We do.
Yes.
Yeah, you all do. You know.
Just looking at scope, I didn't know what the charge of the work group was.
Paul, do you have some thoughts on that, Paul Parker?
Well, Aaron, in terms of our template and what we're working to get to by some time, I guess in the first quarter of 2023, is this a group that is intended to go beyond just focusing on SNF and look at other aspects of post-acute care?
I think as we originally envisioned it, it's a combination of both long-term care and post-acute care when I'm looking back at our reference material. So, yeah.
I mean, I think we could advance. I mean, we've been talking with our National Association of Assisted Living, and Kevin and I have had discussions about some of the other forms of care. So I think we'd be up to entertaining what Laura tees up here and have a conversation about it. I think we've gotten a great start on the SNF side, and I don't want to lose momentum on that. So I would focus on the SNF side for now, but I would include the LTSS stuff personally. Yeah. And I think we have stuff to share on that.
I agree, Joe. They're a different enough animal, though, that I don't want them to confuse or hold us back, because they're different enough that it may be a separate discussion.
Yeah, I think it is. I think it's sort of like a chapter 1, chapter 2 thing, because they're just so different, so different. Mm-hmm. But again, I think those of us on this call now, including Laura and her team and our colleagues, I think we got stuff to offer on that subject. So yeah, I would do chapter 1, chapter 2 parallel. And
I think we would want to convene a different group, because this is
sure. We want their voices
from care SNF group here.
Absolutely.
Any parting thoughts, Laura?
Happy to work with whatever structure. I know there's a certain set number of work groups set up, so we'll join whatever the chairs decide.
All right. Well,
see, Nelson joined.
Hey, Nelson.
Thanks, everyone.
We're actually about ready to wrap up.
And you'll be hearing back from us as far as a future meeting and an agenda for that meeting.
Sounds great.
Thanks very much.
Thanks, everybody. Bye-bye.
Thank you. Take care.